Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today we welcome Tonya, Jagneaux, and Hollis O'Neill. Both are pulmonary and critical care physicians. The KevinMD article is "The Deadliest Condition in Emergency Departments Deserves a New Diagnostic Approach." Tonya and Hollis, welcome to the show.
Thank you,
Thank you,
Kevin.
Kevin.
It's great to be
Thanks
here.
for having us.
So, Hollis, I'm going to start with you. Can you tell us the events that led you to write this collaborative article, and then tell us what this article is about for those who didn't get a chance to read it?
Sure. Yeah. So, for years, for about the last 10 years, our hospital system and a group of physicians from LSU has been working in conjunction with a biotech called Cytobel in developing a novel sepsis diagnostic. And so we've been working with our ED providers, critical care providers, ID providers, and kind of doing some of the preliminary work. And then in 2021, did a multi-centered study looking at this, as a diagnostic test for sepsis. And then ultimately in late 2022, had it FDA cleared. Then in August of 2023, we implemented the test for use in our emergency department. And, the way we did that was really a big combined effort between IT. Dr. Jagneaux is our chief medical informatics officer, so heavily kind of IT-based screening process for patients who walk into the door looking for signs or symptoms of infection. It's a sepsis diagnostic, and so we wanted to be very clear in whom we actually applied the test. And so Dr. Jagneaux was kind of instrumental in developing that process and integrating this into the electronic health record. It is also led by our quality department. Dr. Chris Thomas is one of our partners, and he's also the chief quality officer of our health system. And so then kind of in conjunction with our ED providers, put this sepsis diagnostic into clinical use and started in August 2023. The test reports back a probability of sepsis in basically a low, intermediate, and high probability. And so we developed treatment pathways for that. One of the things that happens is that for the high risk population, so what we call an interpretation band 3 result, that is a critical value that's called back from the lab to the ED, and we go find those patients and begin sepsis care right away. Some of those patients, our ED is big and busy. We see, 75, 80,000 visits a year, 800 bed hospital. So big and busy, lots of turnover of patients. Some of those patients are in the waiting room when the test comes back because Dr. Jagneaux had developed a process to order this at triage. Often that result comes back before the doctor's even seen the patient sitting in the waiting room. Well, we go get those patients out of the waiting room, bring them. Now that obviously creates a resource drain on the ED because the reason they're in the waiting room is because there are no beds. Mm-hmm. And so now we're moving patients to the hall, we're delivering care in kind of non-traditional areas in the ED. So the question was, are we doing the right thing? When we go identify these patients and we pull them back, number one, are we actually getting them back faster? Number two, are they the right patients? Are these patients with sepsis? Are we delivering sepsis care to these patients faster? And so the crux of this article was looking at that population of patients, those patients who were in the emergency department, in the waiting room when the test came back, and we go, physically retrieve them from the waiting room because they have a high probability result. And we found that the answer is yes to all of that. Number one, we're getting them back faster. So those patients with that band 3, that high probability result, they get back into the ED an hour faster than their counterparts. Number two, are they sick? And the answer is yes. 90+% of those patients are admitted to the hospital. Next question is, well, do they have infections, right? So you can't have sepsis without an infection. The answer is yes. 90+% of those patients have infections. And then the next question is, well, do they go on to develop sepsis? And the answer is yes. Over 50% of those patients that we go physically pull back from the emergency department will be discharged with a diagnosis of sepsis. And so ultimately, what this told us is that we are able to identify patients with occult sepsis using this rapid diagnostic for sepsis. It's a host response tool, but we can find them when they don't look that sick. What does that mean? Well, that means that a seasoned triage nurse sent that patient to the waiting room, waiting for results of laboratory. Nobody, I think, would willingly send a patient with sepsis to the waiting room to wait for a test result. But the reason they go out there is because they just don't look that sick. Their underlying biology says they are, but their overall clinical presentation says they're not. We're able to identify those patients, get them back, and deliver care more quickly.
Sure. So before talking about this technology itself, Tonya, let me ask you, what are the traditional diagnostic approaches to sepsis, and talk about some of the clinical limitations they have and the repercussions that we currently have with traditional methods of diagnosing sepsis?
Yes, I mean, pivotal to how the change management occurred with this test. Prior to that, as many physicians know, sepsis presents in a varied ways. It's complicated because of different patient presentations, as Bud just described. They can look fine and be critically ill, or they can look critically ill and not have severe sepsis. And we also, because of electronic health records, had this barrage of predictive tools and maybe sprinkle in there a few biologic tests that would offer some sense of maybe high risk. But I think the greatest challenge was the pre-existing sepsis alerts that many hospitals had deployed. We had as well. And what they do is they will tell a story of maybe sepsis and generate actions that often result in alert fatigue or overutilization of resources. And so we were in that mindset with, both physicians and nurses, and it was really a negative tone to a sepsis alert. If you mentioned that, most of the time, because they had experienced the low positive predictive value of those tests, it was almost as if there was no capacity to alert because they had been so over alerted and had so much noise.
Mm-hmm.
And so that was a big deal. And now we have this test that really brings promise. We need to order it. We need to be able to find out who's the right patient and the process to make sure you can derive what was truly a biologic function that we needed to translate over into the clinical bedside. So that was a critical piece, and it's been a journey. Medicine is always about discovery and improvement, but alert science is interesting in that people are very hesitant to turn things off to miss things. But when you look at how they perform, they also result in the inability to see anything relevant when you are alerting all the time, and not just sepsis. The electronic health record
Mm-hmm.
offers a lot of alerting to the folks who are at the bedside delivering care, and we really had to try to figure out how to highlight the needle in the haystack
Sure.
for those folks who truly needed attention, who needed to be pulled out of the waiting room, or even just in the front of a presentation looking critically ill and it's not sepsis, and you're not going down a completely wrong pathway because the patient looks so sick. And sometimes the default was, this could be severe sepsis. Let's do, the whole package, fluids, antibiotics, etc. So yeah, that was, the starting point, and it required a dedicated approach. And thankfully working with a great team, we were able to do that. But this is not just simply, deploy a test, put it in the ability to order, and just, let's see what happens. Much more to it than that.
So, Tonya, just to follow up on that, just to clarify that the current biomarkers that we traditionally use for sepsis, like the procalcitonin levels, you're saying it doesn't have the predictive accuracy that you need to make sure that patient's on the right diagnostic path. Is that fair to say?
Correct. Yes. The ability to decipher with this test, IntelliSep, it's much better. In addition, the negative predictive value. And so being able to say no, and this is not sepsis, is just as important as being able to say this is very likely to be severe sepsis, regardless of the clinical presentation. And I think that's, again, the challenge of sepsis is how varied it presents with the variation in severity across that presentation spectrum. So IntelliSep has been demonstrated to parse that out. There is a middle zone, there's a yellow component, but that there's still a heightened sense of awareness in that you're going to work up the patient, but still have in the background that the risk for sepsis is still higher than in what we call the green category, which if you're green, we can put the brakes on overutilization of antibiotics and fluids and give a sense of what we think is, comfort and confidence in the providers to not proceed, and be able to pull back, thus allowing those who are sitting in the waiting room to have a bed and come back. So, it is interrelated in the ability not only to drive the right decision-making identification for sepsis, but also correct diagnostics when it's not. And there's a true value into being able to decipher one way versus the other, critical or not, sepsis or not, going forward.
And Tonya, just just to clarify, if there is a delay in the diagnosis of sepsis, just give us an idea of the clinical impact on a patient if there's a delay in diagnosis.
Yeah, there's a lot of numbers out there, but, and, Bud, certainly correct me if I'm wrong, but every hour your mortality can increase about 8 to 10%
Mhm.
if we're missing it in the septic shock population. And, traditionally septic shock was a 40 to 60% mortality. So it is a time sensitive disease. And we talk about sepsis in the same way we talk about a heart attack or a stroke. Like, time is muscle, time is brain. And in this case, time is life saving, in the sense that, if you need antibiotics and fluid resuscitation, the earlier we get that to the right patients, the more likely they are to not die, but also not suffer morbidity, prolonged hospitalization on mechanical ventilation, deconditioning, not being able to return to function in a short period of time. So we recognize that. And the full approach to those patients obviously can't be done for everyone who looks septic by the
Mhm.
traditional SIRS criteria. So it was very important to try to identify folks upon triage who needed the test and be able to have a process to highlight the result, so that if there is a red sitting in the waiting room, someone is aware and goes get that patient. And so it required still using some traditional vital signs, questions, and triage. That's the only thing really available in the electronic health record to start the logic. So we did borrow from SIRS, but we went a little bit more specific, and also we don't want to take away the value that triage nurses have in asking about mental status changes. Do you think there's an infection present in hypotension?
Mhm.
So in that set of criteria, vitals, and those questions, if there's a trigger, we said we're going to order these sets of labs, and IntelliSep was part of it, in addition to chemistry, CBC, and lactic acid, and what we call initiate sepsis care trigger, which highlighted that that patient potentially has sepsis, and it also gives the checklist of what's been done so far. And within 20 minutes, whether the patient's been brought back or is in the waiting room, we're usually looking at the result.
Mhm.
In critical areas, and I think very important, where we have time sensitive diseases that have also declared themselves, we don't slow them down with this process. And that was very important for nurse buy-in. Like, you're going to stop me and I'm trying to take care of a stroke. You're going to stop me and I'm trying to take care of a heart attack. So it was not only like, how do we handle sepsis, but how do we handle the triage process, thinking about other time sensitive diseases that come through, and making sure we are, you know, sort of standing in the shoes of the human being at the
Mhm.
point of decision making.
So, Hollis, tell us about the technology behind this new diagnostic approach. You mentioned host response technology. Briefly
Yeah.
talk about the science behind it and why this new test works.
Yeah, so the science behind it is actually really interesting, and it is elegant in its simplicity. So the fundamental concept that we look at is one that's fundamental to really every piece of biology, that they start teaching you about, when you're third, fourth, fifth grade, right? And that is that in biological processes, structure and function tend to be very tightly related. So it stands to reason that if the function of something changes, then its structure may also change. So let's bring that down to the level of the white blood cell, specifically neutrophils and monocytes, those cells of innate immunity that are involved in this, very vigorous sepsis response. When those cells become activated, their function has changed from a resting quiescent neutrophil monocyte to an aggressive, machine that is turned on to detect and kill, right? That's what they do. Their structure changes. Their nuclear architecture changes. They unwind their chromatin. In the case of neutrophils, they can undergo a process called netosis, where they release their chromatin into the circulation. We know that these processes are beneficial, but in certain situations, they can be pathologic. So in situations where you have netosis in the general circulation, that can lead to microthrombosis, inflammation, organ dysfunction. Those cells don't need to be activated in the general circulation. They should be activated at the site of the infection. So what this test does is it uses peripheral blood from a purple top tube. It uses a tenth of a cc, using microfluidics and some technology that was developed by a gentleman named Dino DiCarlo, who's now the chair of bioengineering at UCLA. He kind of discovered the theory behind all of this, the process, the microfluidic function of this. We can basically squeeze tens of thousands of white blood cells, watch them squeeze using microfluidic, exposing them to hydrodynamic forces using microfluidics. We can watch them squeeze under a high-speed camera that takes about 500,000 plus frames per second. We can analyze the video and tell you which patients have activated innate immunity based on the structural changes that we can visually see under a microscope. We look at, again, tens of thousands of cells. It takes a couple of seconds to capture the data, video data, and it takes a couple of minutes for the computer to analyze the video data. And it results in a score called the IntelliSep index at 0.1 to 10.0 for increasing probability of sepsis. We then divide that score into 3 interpretation bands: low, intermediate, high probability. Technically, the way the FDA looks at it, band 1 is low probability, band 3 is high probability, band 2 is in the middle. The way we operationalize it in the hospital is low, intermediate, and high probability of sepsis. Our ED, they like to see colors, so we do green, yellow, red for low, medium, high probability. And then we tied that to action. So the technology's simple. You look at the structure of white blood cells using fluid to squeeze them, just like if you were to pick up a baseball and a tennis ball, you could squeeze it and feel the difference, right? A baseball is hard, rigid, as a tennis ball is a little bit squishier, right? You can feel that difference. That's what we do. And I think the important thing is it takes 1/10 of a cc from a purple top tube. There's no incubation. There's no real preparation. It takes about 10 minutes from sample to result.
How accessible is a test like this? Is this something that your institution is trialing out? Is this accessible nationwide?
So it is, it's on the market now as of, FDA cleared as of December 2022. We were the first health system to use it in our hospital, our flagship hospital. It's now in all of the hospitals in our system, all the hospitals of any, kind of reasonable size in our hospital. We have some critical access hospitals where I don't know that the utility, we haven't really sorted that out yet, but it's in one of our smaller hospitals is about 45 beds or so, up to our biggest, that's 850 beds. About 5 hospitals in our system are using it. We're starting to see improvements. We've had it for over a year at our flagship hospital, but we're already seeing reductions in length of stay at the other hospitals that have implemented it. So, those, especially interestingly, especially in those band 1 and 2 patients. And so as we track that more in our flagship hospital, we've seen reductions in length of stay, reductions in cost, reductions in mortality. And so it really works. And I think that the reason is complicated. A test never saved anybody's life, right? It's the action that results from that test. It's the doctors, the nurses, the allied health professionals, the health system that really brings that impact to the patient. So it's what we do with the result. It's how you apply that test. And I think that that's important in how we look at it. And Cytobel, the company that has developed the test, has really said, we are not selling a sepsis diagnostic. We're selling a solution that is everything from screening to testing to adoption of these principles and how you manage these patients. And the way I describe it to ED providers, imagine a world that we treated chest pain without the EKG. Just imagine that, right? Somebody comes in and they start complaining of chest pain, but there's no EKG. So you have no first step, no structure around which you can build your treatment for chest pain. And then complicate that by the fact that, as we all know, a certain percentage of MIs will present without chest pain. And so now, you're really looking at non-specific things and you have no structure around which you can build it. So this test, implemented in the right way, really brings that structure, similar to how an EKG brings structure to the diagnosis, management, treatment of patients who present to the hospital with chest pain.
And is this test covered by Medicare and private insurers?
So most of the patients who are tested, most of them are admitted to the hospital just by the nature of their presentation to the ED. So it generally rolls into a DRG. The test, Cytobel does have a CPT code and are currently working with certain payers to figure out how to get that reimbursed. That takes time. It takes, on the order of years to get all of that worked out. So Cytobel is currently working that out. And to your question of, is it available? It is out there on the market. Looking at different health systems, Medical College of Wisconsin in Milwaukee has implemented it in their flagship hospital. and a couple of other hospitals are going to come online early in 2025. And so it's out there, certainly out there for use.
Sure. We're talking to Tonya Jagneaux and Hollis O'Neill. Both are pulmonary and critical care physicians. The KevinMD article is "The Deadliest Condition in Emergency Departments Deserves a New Diagnostic Approach." Now I'm going to ask each of you just to end with some take-home messages to the KevinMD audience. Tonya, let's start with you.
Well, it's been a pleasure to work with Bud on this going forward. And I just think that it's a rare time where you see such a breakthrough, I think, in the biology and diagnosis of sepsis, and having experts bring that sort of our, mechanical and engineers. And then it's paired with what I feel has been a really informative and good practice in learning and the action with implementation science. The two together were absolutely necessary to bring this as a successful test to the patient. And so I think that that's a lesson. If there's another great widget that comes out there for medicine, that it has to be considered part of a process, and implementation science is critical to understanding how to make sure that from a cost efficiency and quality appears at the bedside in the right place for the right patient at the right time.
And Hollis, we'll end with you.
Yeah, so I think there are a couple of things out of this. Number one, it shows just how innovative we can be, and I think it requires good partnership. And I think if you look at what we've done, Dr. Jagneaux and I are faculty at LSU, so we're academicians at heart. Cytabel is industry. Our health system is a part of it's a Catholic health system. We're in the flagship hospital, and so when you bring those three together in true innovation and true partnership and innovation, it really shows you what we can do. This technology was born out of the ED. Every single study we've ever done has been done in the ED looking at this problem. And so it's not a surprise. Dr. Jagneaux and I were not surprised by the results we saw. We did the research. We watched it come through. We watched it grow up, if you want to say it that way. I think, her point of implementation and the teamwork that it takes, this is everything from the triage nurse all the way through, to the people discharging the patient. This is a huge team effort, not only in development, but also in implementation. Our quality team was actually unbelievable in how they've done that, track the outcomes, because we're all about doing what's right for the patient. And so we want our patients to be better. Tracking those outcomes and seeing how we do that is important to us. It's important to our health system. All of the other things, reimbursement, all those things, our feeling is it works itself out. If you just do the right thing for the patient, this technology allows us to do the right thing for the patient. And so I think that those are, to me, the major take-home messages in how you can actually move these through, get things done, be innovative, but responsible in how you're doing it. The last thing I would say is that as we were doing the research, one of the things that was important to all of us is, these patients who we enrolled, we consented them when they were walking through the ED with possible sepsis. None of them wanted to be there. None of them were happy to be there, but they were all willing to participate in the research. And I think that just speaks volumes of our patients, our patient population, who we have here. And I think that it should encourage anybody who's out there to, if you have the opportunity to participate in research like this, you should, because, the goal is to make life better for our kids, right? And those who come behind us. But I think it just speaks volumes to our patients' population, that they are willing to give a little bit of themselves when they're really in, some of the worst condition that they ever imagined themselves being in, presented to the ED with possible sepsis.
Tonya and Hollis, thank you so much for sharing your perspective and insight. And thanks again for coming on the show.
Thank you. Thanks for having us. Really appreciate it.